I'm James. This is our team: Ellen Hughes, Rosalie Weekland, Rhonda Major-Mack, and Ryan Everett. So this is our team from OHA, and we're pleased to welcome you here this morning. We are very proud to support your work to achieve a safer and healthier Ohio. We acknowledge and affirm your work and your leadership and your commitment to quality and patient safety. We kindly ask, on a housekeeping note, that out of regard for our presenters today, that you take a moment and place all of your electronic devices in the vibrate mode or on mute. All of our panelists and our presenters today are truly our colleagues from throughout the state, and we thank them for their willingness to share their expertise with us. You will have several opportunities today to interact and visit the poster presentations, which are located immediately outside in the hallway. You will also have an opportunity to address questions to our panelists. There are question cards on your table. There are white question cards, and you're welcome to at any time jot down your questions. We will have moderators circulating throughout the room who will collect your question cards and present them to the panelists in advance. Immediately following each session, you are also welcome to address the panelists as well. In December of 2014, the Ohio Hospital Association Board of Trustees approved a recommendation from its Clinical Advisory Committee to focus upon sepsis as a harm reduction measure. Specifically, that directive calls for a statewide reduction, a 30% reduction in severe sepsis and sepsis mortality. And in order to achieve this desired metric, the OHA initiative was designed, and this is a statewide initiative, and I need to make that very clear. It is separate from other initiatives, and it might be a subset of other initiatives as well. But we designed this specifically in mind with our Ohio hospitals. This initiative is going to focus on early recognition and early intervention of the 3-hour bundle. We will build upon the very successful work of the LEAPT initiative that concluded in December of 2014, some of which are here today to present to us. We thoughtfully selected this topic as our keynote presentation this morning for this summit. We would also like to take a moment to express our gratitude to Team Health for their very generous sponsorship of this event. Team Health is one of the nation's largest clinical outsourcing organizations, providing physician staffing and management services to over 500 hospitals across our country. This includes 22 emergency departments in the Ohio area alone. Their physicians and clinicians care for more than 1,000 patients an hour in the areas of ER medicine, hospitalist and intensivist services, and anesthesia. Further, this program is approved by the American College of Healthcare Executives for 1.5 ACHE face-to-face education credits. As with all continuing education credits, we would ask that you please make sure that you sign the attendance sheet that's located on your table. The moderators will collect them with each session, so you'll be signing for each session that you attend. You also have a certificate at your table. We'd ask that when you leave today, you leave one of the NCR copies with the moderators, and also an evaluation tool for your honest feedback, which helps us to plan future programming. And now it's my pleasure to introduce our keynote speaker. Our keynote presentation today is being delivered by a true leader in the fight against sepsis, Dr. James O'Brien. Dr. O'Brien currently serves as Vice President of Quality and Patient Safety at OhioHealth Riverside Methodist Hospital here in Columbus. He graduated from the Ohio State University College of Medicine and completed his internship and residency in internal medicine at the Ohio State University Medical Center, where he also served as chief medical resident. He completed a fellowship in the Division of Pulmonary Sciences and Critical Care Medicine and obtained a Master of Science degree in Basic Biomedical Science from the University of Colorado Health Sciences Center. Dr. O'Brien has lectured extensively on the topic of sepsis and serves as the chair of the board of directors of the Sepsis Alliance nationally. Leading the efforts to decrease severe sepsis and septic shock through early recognition and intervention has truly been a passion of Dr. O'Brien's, as evidenced by his strong commitment to patient safety and quality improvement. We are quite fortunate to have Dr. O'Brien serve as a physician champion to the OHA's statewide sepsis initiative, to which many of you here today have already indicated a similar commitment, and we thank you for that. So now it is my great pleasure to introduce Jim O'Brien as our featured presenter and panel moderator. Please join me in welcoming Dr. James O'Brien.
Well, thank you so much for the kind introduction and the warm welcome. It's truly a pleasure to be here. And it's truly exciting for me for OHA to be helping us to lead us through this initiative. I'll be quite frank as I go through this presentation. I'm living in two worlds right now. So as you heard Jim mention, I am the chairman of the board of directors of a not-for-profit Sepsis Alliance, which is dedicated towards raising awareness of sepsis to reduce mortality. But on the other hand, my day job is working as a vice president of quality and patient safety. And so when I start thinking about trying to tackle this problem clinically, I'm scared. This is going to be really difficult. And I want to be very transparent about that as we go through this. That said, it's something I think we absolutely can do, and in fact must do, because if we don't, we're going to be told to do so. And so if we want to lead on this, we need to step in and actually play that role. How many people were here last night for the dinner? Okay, good. So last night we heard Dr. Raisin, who's the Chief Wellness Officer up at Cleveland Clinic, talk a lot about their journey towards improving wellness. And a lot of it was thinking about healthcare in a way different than what we traditionally do. Quite honestly, our healthcare system is for the most part built up to address diseases once they've already occurred, not to keep them from occurring. The presentation today is going to be much more traditional. I'm going to talk to you a lot more about hospital-based interventions, but I'm also going to try and make the case as we talk that this disease that we think of as an acute illness may in fact be a chronic comorbidity. And that in fact there may be significant survivorship issues that are completely unaddressed and may be contributing in unknown ways to the total cost of care that goes into providing care for these folks. So what I'm going to do is walk us through sepsis as a model for talking about high-value healthcare. Who in your organization is starting to talk about the transition from volume to value? Yeah, we sometimes glaze over a little bit because we hear so much about that. I want to start with talking about my disclosures. So the things that you can see underlined or in bold relate to sepsis. I've told you that I'm the chairman of this not-for-profit. I don't receive any salary there. I do a fair amount of speaking about sepsis. And I frequently donate the honoraria, including the honorarium today, to Sepsis Alliance. So I appreciate OHA for supporting this. Here are the disclosures we don't usually share as speakers. And if at the end of our time today you feel like this was an unbiased presentation, I didn't do my job. Okay? I want to be really clear about this. I think that this is the disease we have the greatest opportunity to change its natural history, not just within our lifetimes, but within the next 5 years. And over the next hour, I hope to make the case for you that we have at our disposal tools that allow that to be the case. It's just an issue of us having the will, the intent, and the commitment to provide better care for our patients. As we go through this, the other thing I ask you to do is to think about this not just in a perspective of being a caregiver or being a hospital executive, but instead think about it as being someone who may be a patient or someone who may be a family member of a patient, because that is an experience we will all have. And are we currently working in the healthcare system that we would choose to encounter? If the answer to that is no, we have work to do ahead of us. So this is the framework in which I plan to address this morning. First is to make sure we have a shared mental model about the disease we're talking about. Second, to give some comparison or some information about what our opportunities are if we use models for other diseases, other medical emergencies, and apply them to sepsis. And then to appreciate and use the components of high-value healthcare as we walk through this to show how if we work on sepsis, we actually have the opportunity to provide very high-value healthcare. So first of all, some level setting. Our current definitions is that sepsis is the systemic inflammatory response syndrome due to a confirmed or presumed infection. Really rolls off the tongue, right? So did anyone get on a treadmill this morning? So who heard Dr. Raisin talk again last night? Has anyone planning to get on a treadmill today? We'll talk about what a treadmill is later for the rest of you. SIRS is having 2 of the 4 following criteria: fast breathing, fast heart rate, abnormal temperature, abnormal white blood cell count. The reason I ask about treadmills is because you get SIRS when you get on a treadmill. You breathe fast and your heart rate goes up. This is not a terribly useful definition. That is where we are right now with the science of this disease, however. Severe sepsis is when that progresses to the point that your organs start to fail. And there are pretty characteristic patterns of organ failure that occurs. Sepsis is the most common reason that people wind up with acute respiratory failure. It's the most common reason for shock. It's the most common reason for death in our intensive care units. So it's something that we see very commonly in our hospitals. Septic shock is the most severe form, where you have signs of either poor perfusion of your tissues or you have low blood pressure. That's really the simple aspect of this. What we also know and have known since the 1980s is the risk of dying goes up for every one of your organs that isn't working right. So when you admit someone who comes in with a doubling of their creatinine and they're on oxygen and they're a little bit confused, that person now has a 50-50 chance of leaving the hospital. So just to level set, nationally, when we think about STEMIs, mortality rate's about 4%. So I just talked to you about a disease that's more than 10 times more mortal than ST segment elevation MIs. So this is something that we have an opportunity if we are going to address mortality. What we realize is this definition is not terribly helpful in talking to the press. It's not terribly helpful in talking to the public. And I'll get to why I think that's a key component of the formula for defeating sepsis. So I'm part of the executive board for the Global Sepsis Alliance, and we put together this phrase to try and help us talk about this. And I struggle with this just in talking with patients and families. One of the things I use a lot is I talk about the fact that our body has an army at our disposal to fight infections. What happens with sepsis is your body starts attacking itself. You suffer friendly fire as a result of that infection that started. That seems to resonate more with people. Right now, for what it's worth, we don't usually even have that conversation. The majority of people who wind up being hospitalized for this disease actually don't know that they had this disease. When we talk about an informed patient, it's really hard for them to be informed if they don't even know why they're in the hospital in the first place. More commonly, they feel like they were in the hospital for complications from their cancer, complications from their COPD, complications from pneumonia, one of my favorite terms. What we certainly know is that this is a growth industry. So this is based on discharge records in this country. Let me orient you. The line you see on the top is discharges in which there was either a primary or secondary diagnosis of sepsis. What you can see is that there's pretty significant growth over the duration of this study. The study, by the way, came from the federal government. So as I say that we need to lead, or we are going to be led, this is something that the federal government is beginning to get interested in. What you can see is by the end of that, 1.7 million hospitalizations annually associated with sepsis. If we were to put up there the hospitalization rate across this country, you would actually see a horizontal line with now in the last several years a beginning to actually be a line that's going down. And those of you who are hospital presidents certainly are feeling that prior to Medicaid expansion. I think most of us have found that with Medicaid expansion, our hospitals are very full. But I anticipate if we look at what happened in Medicaid expansion in other states, in 2 years that's going to start declining again, and we're going to see those volumes start to go down. So the other way of thinking about this is our hospitals are becoming full with patients with sepsis, preferentially. At the time of this study, you could anticipate that about 1 out of 23 patients in an average hospital was there because of sepsis. So this is a very common diagnosis. I like presenting numbers a number of different ways because they mean different things to us. This 1.7 million means that 1 out of 185 of us, on average, will be hospitalized with this disease this year. How many people are in this room? We won't count off. I'm going to say that it's probably around this number. I don't know who it's going to be. But on average, 1 of us will be hospitalized with this disease this year. And then 1 of us will be hospitalized with this disease the following year. This is a disease in which there are 2 levels of awareness. People have never heard of it or they've been personally affected by it. And for all of this, this will be part of our life stories. What we also know is that people hospitalized with this disease 8 times more likely to die than people hospitalized for other reasons. they're also significantly more likely to need care post-hospitalization. The amount of money spent in that care we don't know, but certainly a significant proportion of our patients, for example, going to long-term acute care hospitals, started off being hospitalized with sepsis, and we spend about $5 billion a year just in that small area. So this is significant healthcare resources dedicated to this. More recent studies suggest that in our hospitals, between 1 out of 2 and 1 out of 3 deaths that occur under our watch are tied to sepsis. This is based on 2 different national databases looking at this, with looking at the actual clinical diagnoses, not just discharge records, not just billing data. So if we are going to address improving the health of those patients we're seeing in our hospitals, we're going to need to tackle this. We can nibble around the edges about other diseases, but this is the one that's actually killing people. We lose about 250,000 Americans every single year to this disease. What that amounts to, again, presenting this different ways, there have been 27 deaths on commercial airliners in this country in the last 5 years. We lose that many people to sepsis every 55 minutes. So during the course of this talk today, we will wind up in this country losing as many people to sepsis as died in plane crashes in the last 5 years. If we think about September 11th, and I give talks to our medical students, September 11th is now a historical fact to them, which is really disconcerting to me. We lose that many Americans to sepsis every 4.2 days, and we'll lose that many people to sepsis the next 4.2 days. This is something that we've gotten normalized deviance about, but there's huge opportunities improving this. One thing I should step back and say, a lot of what I'm going to present you relates to the adult population. And I apologize for that. I'm an adult doctor. So I still think that kids are just small adults, and the pediatricians keep telling me I'm wrong. Out of respect to the folks who work in children's hospitals, the data around pediatric sepsis, quite honestly, isn't as robust as it is with adults. That said, we know that pediatric sepsis kills more American kids than cancer kills American kids. The death rate is much lower than it is in adults because kids can tolerate a lot more. The studies are harder to do because the mortality rate isn't as high. So there's been a lot of work about figuring out what other outcomes we can look at. In the developing world, sepsis is a pediatric illness. About 7 million children die annually worldwide. 6 million of them die because of sepsis. And the majority of them are tied to diarrhea or pneumonia. So this is the way that kids die worldwide. And so we're losing generations because of this disease in the developing world as well. Said another way, sepsis kills more people in this country than breast cancer, lung cancer, and prostate cancer combined. Not individually, combined. So if we're going to get to the work of reducing mortality, this is a disease we have to address. Okay, has anyone seen this equation? Yeah, so this is the value equation that I see presented most commonly, which is the way you improve value of healthcare is you improve the quality, you decrease the cost, or you kind of balance the two out. But the notion is that for every unit of cost, the quality winds up going up. So this is the value equation that I see most common. This is actually a more complex equation that I like more. This is one that I've seen popularized by Virginia Mason. Virginia Mason is a health system around the Seattle area, so in Washington. You may have heard of them. They're pretty far down the road in this transition. They got some press earlier this year because they offer a guarantee on their joint replacements. You pay a single price. You have any complications, any problems, you need to go to rehab, you need home physical therapy, it's all included in that price. So they got a lot of press around that, as you can imagine, because they're now taking on the risk. What they suggested is maybe we should look at this a little bit differently, and it should start with this notion of appropriateness. So if I am a heart surgeon and I wind up having great outcomes, none of my patients die, they all love me, and I'm the lowest cost provider, and none of my patients needed heart surgery, I'm not providing value. And the data out there suggests that we wind up providing a lot of inappropriate care in this country. Is anyone familiar with the Choosing Wisely campaign? Okay, so some people. So Choosing Wisely campaign is actually a joint venture between Consumer Reports and a number of professional societies. And so for each of these professional societies, they'll talk about, in allergy and immunology, these are the 5 things you shouldn't have done. So it's starting to outline those things that are not appropriate, that are actually consuming some of the $2.7 trillion we spend on healthcare in this country. So there's beginning to be some of that engagement. The second piece of this is combining the outcome experience of patients. And then it's divided by, instead of by cost, divided by waste. So what waste is non-value added expense. And the way that you define something as being non-value added is, would the customer pay for it? When you start framing it this way, you stop looking at your workforce as being your biggest area of cost. Because most patients want a doctor. Most patients want a pharmacist. Most patients want a respiratory therapist. They want a nurse. They're willing to pay for that. So how do we instead focus on the stuff that actually is not value added? So how do we focus on the work that our nurses are doing that the patient doesn't actually want? Some of it we have to do, but some of it we're doing that isn't providing value to the patient and we aren't required to do for documentation reasons. How do we focus on those pieces of it? So I like that because it reframes us having to think deeper about what are we doing and why are we doing it? And let's stop doing that stuff that doesn't matter. So I'm going to use this as a framework for walking through this presentation looking at sepsis. So I'm going to start with outcomes. So this is a slide that I use a lot. This is a study that encompasses patients with septic shock, so most severe form of sepsis, low blood pressure, who present to an emergency department. This includes hospitals in the United States, Canada, and Saudi Arabia. And what they did was they took these 3,500 patients and they lined them up in order. They set time 0 as the time that their blood pressure was low a second time. So you had to have a low blood pressure, we did something, it got better and went back down, or we did something, it didn't get any better, it was still low. That second time, not the first time, the second time was time 0, and then they looked at how long did it take us to give that person appropriate antibiotics. And by appropriate, what I mean is the antibiotics would work against where they were infected, and if we isolated what the infection was, against that bacteria. The black bars are the percentage of patients based on the time they got antibiotics and their survival rate. So what you can see is that if you got antibiotics within 30 minutes, over 80% of patients survive. What they found is that on average, every hour that passed without appropriate antibiotics, your risk of dying went up by about 8%. This may be the most effective therapy we have in all of medicine. I mean, if we think about what we do for STEMIs, the intervention for using thrombolysis was on top of aspirin. The effect size was a little bit smaller than aspirin by itself. So we're incrementally reducing mortality in a lot of other diseases. This one has this big Pareto, this huge bar of opportunity related to antibiotics. The other thing, again, thinking about yourself as a patient or as a caregiver, the median time, the time to which half of the patients in this group got antibiotics was 6 hours. Who knows the median time to antibiotics in your emergency department? Good, so we've got some people. Who knows your door to balloon time? Okay, this shows that by paying attention to this, we actually can drive improvement. And so that's why I'm so excited about what the OHA is doing. So some other data about this. So this is this same data, and I'm just presenting it differently. So I'm grouping these patients by when they got antibiotics, and the reason is I want to throw this up against what we've gone with ST segment elevation MI. The blue bars are the mortality of the patients in those group. The red bars are the percent of patients that fit into each of those categories as far as when they got antibiotics. And what we want to do is we want to shift it so we're giving these antibiotics sooner. This is the same model of what we did with ST segment elevation MI. These are data from ST segment elevation MI presenting in the emergency department, observational data, very similar to that septic shock data I just showed you. And this is one of the things that drove us to trying to get people into the cath lab. But some things to point out. First of all, look at the relative mortality here. We're talking about a mortality of between 4 and 6%. And look at the effect size. We're reducing mortality from 6 to 7% to 4 to 5%. Now that matters because by doing that, what we find is if we got door to balloon times less than 2 hours, and I know, Marianne, wherever you are, that's not our target, but I'm using that as an example. By getting door to balloon times less than 2 hours in all of our patients who present with this diagnosis, we'd save 13 people a day. That's a reason to do it. Let me show you what happens if we think about this with septic shock and we talk about giving antibiotics to these people within 2 hours. Now we're talking about an intervention that's about 3.5 times more powerful than getting people into the cath lab. And raise your hand if you've got an emergency department that doesn't have antibiotics. This doesn't require an interventional cardiologist. This doesn't involve a cath lab tech. This doesn't involve you needing a cath lab. This involves getting those medications from over there and plugging them into the patient's arm and doing it in a reliable, dependable fashion overall. That 32,000 lives, by the way, is about how many people die of motor vehicle accidents every year in this country. Again, giving you a context for the number of people who die in this country due to delayed antibiotics in septic shock. For what it's worth, the data on severe sepsis, people who have organ failure without shock, also suggests that timeliness is very important for them surviving and their organ failure getting better. The difficulty in that analysis is the time zero, because now you're talking about, for the most part, lab tests. And so it's much murkier in trying to figure out the effect size the same way with this, which is based on blood pressure. So this is additional data about antibiotics. This is the same investigators. Now they've got over 6,000 patients. They've presented the exact same way. The difference here is what they're doing is they've put these patients in order, and they'll look at the first 250 patients, the people who got antibiotics soonest, and they are creating a rolling average. First 250, move over by one patient. 250, move over by a patient, 250. That's what this black bar is. What you can see is this black bar is actually not a straight line. It's an exponential decay. So the slope of this line is actually a lot steeper for the first 12 hours. And so during that time, your risk of dying goes up by about 1% for every 5 minutes that passes without appropriate antibiotics. So when we talk about time is muscle and time is brain, it absolutely applies to this disease. If you look at the next 12 hours, doesn't matter as much. The slope winds up becoming a little bit more shallow. And after 24 hours, it actually doesn't matter if you get antibiotics. Let me be really clear, I'm not advocating for not giving those patients antibiotics, okay? But the data suggests that you shouldn't expect that that's where you're going to get your effect. So if your intervention is having an infectious disease doctor round on these patients 18 hours after admission and make sure they're on the right antibiotics, that's good from an antibiotic stewardship perspective, but as far as getting it right on the front line, that's not going to wind up affecting it. I'm an ICU doctor by training, and most of what we've done around sepsis has been ICU-based. The fact is that I have very little to offer patients at that point. What I can do is try to prevent more harm to them. But if we didn't get it right before they get into the ICU, at least in the hospitals I've worked in, where patients don't immediately roll from the emergency department into the ICU, it's going to be really hard for us to actually affect change for those patients. So we need to get it right on the front door. Okay, so moving past that and thinking about appropriateness. One of the things that is emerging is a picture of this disease in which this is not an acute illness where success is defined by discharge from the intensive care unit or discharge from the hospital. This is data that is actually a really good study, even though it comes out of Michigan. A friend of mine, Jack of Washington, did this study, and they have a cohort of people that they followed. They started off with them between the ages of 50 and 70. It's called the National Retirement Study. I'm hoping to be part of that when I reach 50. That would be great. And they follow them every year. And so they've got 20 years of follow-up with these patients. And what they did was they compared people who were hospitalized for severe sepsis and survived to people hospitalized for other reasons who survived. What they found is that the people who were hospitalized with severe sepsis were much more likely to develop what they called moderate or severe cognitive impairment. Now, this is problems with executive functioning. So executive functioning being things like reasoning, so visual spatial reasoning, being able to draw complex figures, calculations, being able to balance your checkbook, memory. Those are the sort of things that they found as being abnormal. I'm not a neurologist, but it sounds a lot like dementia. These seem to be fixed problems for these patients. These are things that lead to significantly more limitations in their activities of daily living as well. So what we're doing is exposing these people to an acute disease that gives them a chronic illness, otherwise known as frailty. And so as a result of that, it's not surprising that these folks wind up being back in our hospital. Based on this, Just amongst the elderly population, there are approximately 20,000 new cases of cognitive dysfunction every year in this country among sepsis survivors. So these patients are going to the primary care offices complaining. Usually their spouses are complaining because they can't balance a checkbook, or they got lost going to the grocery store. And I can tell you that as we collect stories of people who are survivors, the most common response we give them is one of two. You should be glad you're alive, or we prescribe an antidepressant. We're not getting to the heart of the problem for these patients, and this is an opportunity for us in improving the care they get. Other things that are emerging, and just pay attention even to the dates on these studies, because these studies are all things that have come out within the last 3 years or so, where we are really understanding that this is something that leads to significant functional disabilities for our survivors. It's not something that we always identify for people needing rehabilitation. And what's emerging is a picture of us needing to do rehabilitation for these people when they are acutely ill in our ICU on day one. The ICU is one of the few places in the hospital we still put people at bed rest. We've learned everywhere else that's a terrible idea. We're starting to realize in the ICU that's a problem. We need to resource it appropriately. There's also beginning to be understood there's significant neuropsychological consequences for these patients. PTSD rates amongst survivors of critical illness is only surpassed by people who are survivors of rape. How are we addressing that for these folks? The other thing that's really disturbing is there are a couple studies that now are suggesting the spouses of severe sepsis survivors are as affected by the psychological comorbidities as the patient themselves. So think about that dyadic structure that we've worked on with cancer and making sure that we're supporting the caregiver. What are we doing for these folks? So again, lots of opportunities for us in trying to re-engineer the way we're delivering care, thinking about the whole patient and thinking about them beyond our walls. Surviving Sepsis campaign also freely acknowledges, and one of the things as we go down the journey of improving that we need to acknowledge, sepsis is a way that we wind up dying. Not all of those deaths are preventable, and I would also say very clearly that I have caused worse outcomes than death in the ICU. Does anyone work in an ICU? So there is certainly that moral distress that you feel when you have people who are wind up being hooked up to machines, and that's how they're going to live out the remainder of their lives. A piece of this is going to need to be us getting upstream and talking to people about how they want the rest of their lives to be. Because it isn't just a single diagnosis that puts us at risk for dying. It is also when we start having problems with all of our organs not working well. That is a marker that your body's starting to fail. And one of the common mechanisms of dying is this disease. And so how do we actually get engaged in talking about this with the public and identifying those folks who have been in our hospitals and who have been repeatedly in? And how do we start framing the conversation about how do you want the rest of your life to look? Not timing of it. Because that's what our patients, at least what studies suggest, really want us to discuss with them. Okay, so waste. So it'd be really easy to frame waste purely around money, and I'll talk a little bit about that. But I want to talk about it instead of thinking about it as treatment as a medical emergency. So let's talk about the money piece of it. So sepsis is the single most expensive reason for hospitalization in this country. The estimate's around $20 billion. The average cost per stay is significantly more than people hospitalized for other reasons. And its average rate of growth for hospital costs is also significantly more than hospital costs in general. So if we want to bend that cost curve, this is something that we're going to have to address. Additionally, this is data that came out last week. So Medicare released their expenditures, and this is Ohio data for you guys to look at. Now, a couple things to kind of level set. This is only fee-for-service Medicare. So this is a small fraction of the patients that we take care of. At our hospitals, about 63% of Medicare patients are fee-for-service. I can't tell you what yours are, but that's just a small fraction of the patients who are hospitalized who have third-party payers and things like that. But it tells some pictures. So amongst this population, we're going to have 50 admissions today with these diagnoses that fit into these DRGs. We're also spending $473 a minute to provide care for these patients in this state. So last night, Dr. Raisin talked about the fact that we have one crisis in this country and one only, and that is the spending we have on healthcare. That if we actually turned that around, we'd have a lot more resources to do everything else we wanted to do. But because of the fact that we're spending 17% of what our economy is generating on healthcare, we don't have the ability to do anything else. So this is something that as we're sitting here, it's kind of like being in a taxi cab. The meter's running. The other thing to point out is that's total payments. Medicare's only covering a piece of this. Now, there's another piece of it that sometimes is covered by people having Medigap insurance, so they've got a third-party payer that backs it up, or sometimes they've got to pay this out of pocket. I can't tell from this data what that is for individual patients, but on average, it's about $2,400 per patient. 60% of bankruptcies in this country are tied to medical bills. Is this the healthcare system that we want? I was sharing actually tweets with Jack Awashna last night about some of this, and he sent me a meme bringing up the fact that, does anyone watch Breaking Bad? All right, so Breaking Bad's about a high school chemistry teacher who becomes a meth dealer. Does anyone remember why he does that? He gets diagnosed with lung cancer and he can't afford to pay the bills. So we're turning our patients into meth dealers, is I think what I've taken from that. Anyone working on readmissions? Who's got the solution to readmissions? All right, good. We're going to call on you in a little bit. There's emerging data. So sepsis is a major driver of readmissions. It's not a focus yet, but as we're going to be challenged with dealing with hospital-wide readmissions, this is going to have to be a target for us because it's a lot of hospitalizations, and it's one of the major causes of readmissions. Last night we heard from Dr. Raisin also. He talked briefly about our microbiome. The microbiome are the bacteria and fungi that live in and on us, and I apologize, you're going to itch right now. 90% of the cells that make up the body mass sitting in your chair are non-human cells. So you have 9 times more bacterial cells in and on your body than you have human cells. We are much more bacterial than we are human. That's your microbiome. Hallie Prescott, who's a resident I used to work with at Ohio State, now at Michigan, just published data showing that a big piece of these readmissions are actually tied to infectious complications. And her question is does our initial treatment of these patients, giving them antibiotics, change that microbiome such that they're now more prone to having a new infection occur? We kill off the bacteria that actually keep us in homeostasis, and others then can grow. We don't know that. We also heard last night that one of the ways to improve your overall wellness is to reduce the amount of red meat that you eat. That was one of the things that caused us to ask questions about eating the beef that was served last night. So what occurred to me, though, is one other hypothesis is 60% of the antibiotics we use in this country is used in our food supply. So is it the meat that's doing it, or is it the antibiotics it's bathed in? And I don't know the answer to that. We've been working a lot with the CDC to change their messaging. Does anyone feel like there is a message out there that we use too many antibiotics? Right. Sepsis Alliance was founded by a guy who's a dentist. His 23-year-old daughter wound up getting necrotizing fasciitis after an elective surgery. They did not give her antibiotics because they were worried about giving her diarrhea. That's what they told them. But we're told that. So we've been working with the CDC to actually crafting that message more around smart use of antibiotics. If you're sick and we don't know why, this is a common diagnosis, we need to treat you. When we have more information and we figure out that you don't have an infection, we need to stop the antibiotics. Or we need to customize them based on the culture results we get back. And we need to stop giving antibiotics to the 30% of patients who we say has a cold that we give an antibiotic to. So there are areas that on both sides we need to work harder on. All right, I want to talk to you about a success story, and there are lots of them out in the literature. This one comes from Intermountain Health. So Intermountain Health, is, as many of you probably know, is a health system out in Utah and Idaho. And they embarked on this project to improve quality in 11 hospitals in Utah and Idaho. They focused on patients presenting to their emergency department, not just the people who were kind of sick with infections, but they had organ failure or low blood pressure. And you can see that this is a project that didn't happen overnight. This was true multi-generational quality improvement. Over this time, what they found is about 30% of the patients who came into their ED and were admitted to the ICU had sepsis. Common diagnosis. So worth their effort in screening because the prevalence of disease was high enough. What they focused on was two different things. First of all, must-haves. And this is very much in line with what the OHA is working on, which is called the 3-hour resuscitation bundle. So all patients get a lactate measured, a marker of poor oxygen delivery to tissues, blood cultures, and broad-spectrum antibiotics. The fourth thing that was in there was when we were worried about people's blood glucose. We've now realized that maybe getting people's glucose normal is good, but we don't have the technology to actually do it safely yet. So right now, that's fallen away. So think about those three things. And then if patients are sick, so if you give them those things and they don't get better, they may need things like vasopressors or ventilators or steroids, the stuff that if you go to a critical care medicine conference, we will debate ad nauseum. I have seen pro-con discussions on steroids and antibiotics for about 20 years, and it just continues. We don't know what to do. But what they focused on was this early thing. So here are their results. So the black line is the mortality over time. What you can see is baseline, 21%. So compared to national numbers, that's terrific performance. That's 80th percentile based on data vision numbers. That's terrific performance. But look where they got to. 8.7%. 8.7%. At baseline, when they looked at their adherence to best care, less than 1 out of 20 patients got it. By the time they were done, they got up to 73%. Does anyone have a 73% performance with skip measures? AMI bundle? You'd be in trouble, right? We've topped out those measures. So even getting to this moderate level of performance where 1 out of 4 patients don't get the right care, they saw a significant reduction in mortality. And let's look at why. So first of all, if they had just left things alone, 21% looks great. We don't have a problem. This is what they would have done. They would have used 1,400 more hospital days a year. They would have consumed 266 more ICU days a year, and they would have killed 100 more patients a year. And I see that really clearly because our lack of action, our error of omission is the same as making a mistake. We don't think of it the same way, but had they not acted, they would have had 100 more people die every year, and they would have just lived with it. Here's what they found. So at baseline, I showed you that bundle compliance, and look at the mortality in the patients where they did the right thing. The mortality is pretty similar. The biggest reduction is actually in the people where they still didn't provide the right care. But look, they had fewer things they missed. And again, this is really complex. This is, 11 different elements. And they went from missing 4 on average to missing 1. What they also found was this, is that at baseline, when they looked at people eligible for those other things, so they didn't get better, we had to do more. They found that their care got less complex. So there was still about the same number of people who needed fluids. And so that's why that's one of those 3-hour bundle elements. But look at vasopressors. 44% of those patients did not need them if you provided the other stuff really well. You didn't need to put central lines in these patients. You didn't need to transfuse them. You didn't need to give them steroids. You didn't need to put them on ventilators. If you just did that basic stuff, the easy stuff, really well every single time. This is the stuff that I've found as we've been doing quality improvement projects we get hung up on. Who's going to put the line in? I don't know. But how are we getting the antibiotics in? That's the thing that matters. And that doesn't necessarily need a central line. So if you give us levels of gray, we as physicians will tend to go to that and argue about it. But what we need to be refocused on is the areas that everyone agrees. And how are we going to get to the process of making sure that's done right every time? So if you think about the downstream consequences of these sort of things, and additional cost and additional resources that we expend in these things. So if you work in the ICU, what you do with these patients is you give them lots of fluids, and then you wind up getting rid of the fluids. And because of that, their electrolytes go down, so now you have to replace potassium, and then you keep them on telemetry. So there's all this downstream consequence to the fact that we don't provide good care right off the bat. And most of the data suggests these quality improvement projects have significant cost savings. So there's the opportunity for us to actually do the right thing and make money on it, which is always something that as an administrator is something I want to be able to invest in. So this is something that provides us an opportunity. Other thing, Mortality was lowest in the people who didn't need the later bundle elements. So that's not surprising, right? If you got better, you were better, right? But the other piece is really interesting. For those that needed the later bundle elements, it didn't matter if we did it or not. Mortality was the same. So why are we talking about that piece? Let's focus on the early piece because that's where the real return is. All right, patient experience. I want to talk about engagement. My journey and involvement with Sepsis Alliance finally came to a head after taking care of a 19-year-old. And her picture is still on my wall in my office. Last thing she ever said, "I'm just so scared, I've never been this sick." That's the reason I do this. This is Jen Ludwin, whose picture you see up here. She had H1N1, was in the hospital for 4 months, lost all the fingers on her left hand, 2 of the fingers on her right hand, both legs below the knees. She was a master's student at the time. Jen's taught me a lot about dealing with this disease. And one of the things we realize is we need to have greater engagement from our patients. We need them involved in telling us what they need. And what you can see here from some of the stories we collect at facesofsepsis.org are people asking for help and us not responding in very positive fashions. We've created actually a letter that people can take to their doctor talking about the consequences of sepsis survivorship, and we've gotten survivors to come back to us and say, "My doctor told me I was crazy and that you guys were telling them lies." Is that how we want to be portrayed? Is that the role that we want to play as we engage with our patients? One of the things we work on, I told you, is awareness. This is based on a national sample. This is run by previously Harris Interactive, now Nielsen, because they bought Harris. So this is done by a national polling agency. We'll be getting our 2015 data later this year. This is based on us asking the question, have you ever heard of sepsis? And what % of Americans say yes? So 1 out of 185 of us are going to be hospitalized with this disease. Less than half of us have ever heard the word. We used to ask people who said they'd heard of it to define it, and they gave us definitions for the word species, stuff related to septic tanks. Sexist was an interesting one that there was a definition for. So when we talk about awareness, it's a completely different ballgame than we talk about breast cancer awareness. So there's this gap that exists. We're trying to do some things around this, so you may not know, but September is actually Sepsis Awareness Month. September 13th is World Sepsis Day. So feel free to celebrate. The colors tend to be black and red. There are websites related to this, and you can get information related to that. We also locally are having our 7th event, so this is a shameless plug, but also an invitation. We do a sand volleyball tournament in Grandview, Ohio. We are up to our largest group of people participating ever. It raises money for Sepsis Alliance. It's a collection of people who work in healthcare, people in the community, as well as survivors and family members who come out and join us for this event. All money goes to Sepsis Alliance. You can check things out at the website. If you want to buy a t-shirt, you want to register soon, you got to get in very quickly because the event's coming up very soon. This is our 7th one of these. But if you think about this and you think about the progress that's been made in things like breast cancer and HIV, we always need the public. Does anyone in the room have any sort of standard team that responds to a patient who could have Ebola? Okay. What about who has one responding to sepsis? Okay. One of the reasons for that is because we were scared about Ebola. And the federal government got involved. Why did the federal government get involved? Because the public was scared and concerned and wanted action. So we need the public because that 44% is probably the same rate that we will see in our representatives. They're members of the public. They respond to their constituents. And so if we aren't engaging them around this, we're not going to make progress. And here's some data suggesting why that's the case. That first column is the number of deaths. You can see the dates back in 2009. And then you can see the line next to it is related to the funding for those diseases by the National Institutes of Health. National Institutes of Health gets its budget from Congress. Congress, in many ways, winds up telling them what they're going to spend money on. What I've just done is divide the funding by the number of deaths. So what you can see is success stories. HIV and AIDS. HIV winds up being funded at $306,000 per U.S. death. Now, I understand completely that that research also benefits people around the world. Breast cancer, $17,000 per death. Those are success stories. Look at sepsis, just under $200. So this is a disconnect burden of disease relative to how we're resourcing it. So what I want you to think about is that we are going to need to focus on the right care at the right time for these patients. And the focus needs to be on identifying these patients. We need to realize that we're treating when we don't yet know. There's no diagnostic test for sepsis. There is not an EKG, there's not a troponin, there's not something that tells us yes or no. We need that. We don't have it right now. We have to allow that we are going to need to treat people in a time of uncertainty. And we're going to have to readdress our therapeutic plan as we go forward based on more information that comes in. But to address this, we're going to have to work across boundaries within our hospitals. And then we're going to have to work across boundaries outside of our hospitals. Because if we're only focused in the ICU, that's not where these patients present. 80% of patients in US hospitals who are hospitalized with sepsis do not have nosocomial infections. They come in the emergency department with this acquired outside of the hospital. In general, this is thought of as a hospital-acquired infection. I could say that because the single hearing that's occurred on Capitol Hill related to sepsis was all about healthcare-acquired infections. But if we're really going to drive this, we need to get out to where those patients are. And then we need to figure out how do we actually provide the transition for these patients moving through our hospital, because they're going from the emergency department to the ICU, to the ward, and then how do we help to provide that transition and that safe landing and instruction for these people as they go back into the community. And some of what we're going to have to do is start having conversations about the fact that this is probably the terminal event for this person. That can be a high-value interaction with patients and families, and we have opportunities to do this. We need to prepare them for some of the long-term consequences. We don't have good predictors for who is going to have cognitive dysfunction. There appears to be some association with two things. Severity of illness when you're first here. So someone with multi-organ failure more likely to develop it than someone who just has single organ failure. And probably the frequency of delirium in the hospital. What we don't know is how to prevent delirium. The one intervention that seems to reduce delirium, acute confusion in the hospital for ICU patients, is early mobility on day one. And it may be that what that does is it causes us to think about that patient differently. They aren't an extension of their life support machines, but instead they're a grandmother or they're a father. They're actually a patient who can do things so that we're less likely to make sure that they can continue to be an extension of that life support. It also may be that what it does is it tires that patient out so they actually sleep. The benzodiazepines that we use as sedatives in the hospital to make people sleep gives them all stage 1 and stage 2 sleep. That sleep's not restorative. And so what you're doing is we're actually creating sleep-deprived patients, which probably causes them to be more likely to develop delirium. But we think we're doing the right thing. So there's a lot of work that needs to be done around that. And then I think the last thing is we have every opportunity around this to engage our patients. At the very least, I encourage you to use the word. It's really hard. I could tell you that it winds up being on average a 20-minute conversation. And you will wind up hearing things like, well, if this is so serious, how come I haven't heard of this? Or, how is that possible? It's just an infection. We need to start breaking this cycle. The most common, 80% of physicians who talk with patients and families about sepsis use the phrase complications from. 10% of us use the word, and part of the reason is we expect that 60% of the patients aren't going to know what we're talking about. So it's easier for us to do a drive-by and just inform them. But that's not actually engaging them. So this seems really, really hard. It is. Many of you who have seen me speak before have seen this slide. I use it a lot. I'm not going to ask who remembers this being said, okay? But a couple things that I want you to pay attention to. So when this challenge was laid out, look at the date and look at the date when that challenge was accomplished. This isn't something that took a decade. And it was incremental, right? We started off with high-level flights within the atmosphere. Then we started with low-level flights outside the atmosphere. And then we started orbiting the Earth. Then we started going out farther. And it was an incremental work that got us there. We didn't get there in one jump. But we got there because of commitment and will. Do you guys, so people who haven't seen this slide before, what's that picture of up on the left side? Anyone know? That's the Apollo guidance computer. The Apollo guidance computer had a RAM capacity of 16K. To give you some perspective, the JPEG of the picture of the computer was 258 megabytes. So the picture of the computer would nowhere come close to fitting on the computer that flew us to the moon. We did this on the basis of using slide rules with people who said, we're going to do this, and we're going to move forward, and we're going to be focused on executing on this. This is, I think, the pathway that we have to offer. The other thing that I like to bring forward is, this is a follow-up quote, because there was a lot of pushback. Not everyone thought this was a great idea. I think now it's kind of been romanticized that we were in this race to the moon with the Soviets. That's partially true, but the economy was tanking, we were in a civil rights crisis, and the Soviets were putting missiles 90 miles off our shore. And there was a lot of comment about to the president, how can you be doing this now? We got all this other stuff to deal with. This is way too hard to do. So we're dealing with the transition from volume to value. And we're being asked to do more with less. And we need a more engaged workforce. And we've got more burnout in our workforce than ever before. How are we going to do all this? And his response was, that's exactly the reason that we do this. We don't do it because it's easy. If it's easy, we would have already done it. We do it because we want to do something better. And to do that means we have to challenge ourselves. That's exactly what this journey is going to be. And I'm very proud to be a part of what OHA is leading us on as we go forth in saving lives in Ohio, not a decade, but in the next year and the year after that. Because think about how many birthdays, and for me, it causes me to think about that 19-year-old. Because when I get frustrated, I can see her eyes. And I know that there's something I owe her in going forward. I thank you very much for your time and for your attention this morning. We're going to have a conversation up here. Please put in your questions so we can make sure this is a conversation. But thank you very much for your attention.
Thank you very much, Jim, for that absolutely inspirational presentation and a call to action for us, and also for endorsing the statewide sepsis initiative as well. Our panel today is comprised of 3 of the hospital quality leaders who were participants in the one-year Leading Edge Advanced Practice Topics Initiative in 2014, better known as LEAPT. Their hospitals demonstrated rapid cycle improvements in early recognition of sepsis and in implementation of the 3-hour bundle interventions. The hospitals represented on our panel today are Akron General Medical Center, the James Cancer Hospital of The Ohio State University Wexner Medical Center, and Union Hospital. I would like to introduce our panelists. To my immediate left is Carol Murphy. Carol serves as the Director of Quality Improvement at Union Hospital in Dover, Ohio. She holds a diploma in nursing from Massillon Community Hospital, a Bachelor of Science degree in nursing from Malone College, and a Master of Science degree in nursing from St. Joseph's College of Maine. Our second panelist to my immediate right is Carol Colussi. Carol is the Director of Quality Improvement and Patient Safety at the James Cancer Hospital here in Columbus, Ohio. She holds a Bachelor of Science degree in nursing and a Master's of Healthcare Administration degree from the University of Texas. And finally, our last panelist to your far right is Christine Boulden. Christine is the Quality Improvement Coordinator at Akron General Medical Center in Akron, Ohio, where she focuses her efforts on the Surviving Sepsis campaign. She holds responsibility for the data abstraction and compilation, investigation of outliers, preparation of cases for physician and nursing peer review, and for providing education services. Christine holds a Bachelor of Science degree in nursing from Kent State University, a Master's degree in nursing leadership and management from Walden University, and is certified as a healthcare accreditation professional. So at this time, I will turn the podium over to Carol Murphy, who will lead our panel presentation. And just as a reminder, as Dr. O'Brien mentioned, there are question cards at your table, so feel free to jot down your questions. Our moderators will be around to collect them. Thank you. Carol?
Thank you, Jim, and I am really appreciative of the opportunity to share our sepsis journey that we had in 2014 through the LEAPT project. And just to let you know, I feel kind of like the Davy with Goliaths. Union Hospital is a small community hospital in Tuscarawas County, Dover, Ohio. And we've been in existence for about 109 years, and we've gone through a lot of changes since then. These are some of our statistics as far as our volumes. As you can see, we do have a very high volume emergency department. So that's very significant as we talk about what we've been able to do with sepsis. We decided late in 2013 to participate in LEAPT in 2014 because we knew that coming down the road we were going to start to have to report our sepsis metrics to CMS. We knew that we had sepsis cases in the hospital. You know, we saw the patients dying and being debilitated every day by sepsis. And we did have a very dedicated staff who wanted to work on this. I feel being here today that I'm kind of an imposter because our sepsis coordinator is on vacation. She could not be here, Vani Kahaney. She is very passionate about sepsis, and she did an awesome job leading this project, and she continues to as we move forward. I'm also very glad to be here today with another member of my staff, E.J. Seibold, if you want to give a wave. She's our evidence-based practice specialist, and she does many of the order sets, protocols, and so forth that we use whenever we do a quality improvement project. Our sepsis team that we put together consisted of, like I said, we had representatives from quality improvement. We included the ED physicians and nursing, ICU and inpatient nursing, our hospitalists, intensivists, infection control, laboratory. Our CDI specialists were kind of helpful in being on our team for sepsis last year because they were able to identify cases earlier that we could take a look at and see, you know, where did things go wrong earlier, you know, whenever we didn't identify sepsis in the early stages. So getting started, of course, it's tough. Nobody wants to be the person that's actually going to do this, and we found that out whenever we decided we were going to start this in our emergency department. We wanted that early identification of the patients. So we went to the ED docs, and the reception wasn't that welcoming. So we decided to kind of take an alternate path, and we went to the nurses. And so what we were able to do was to work with ED, work in triage to develop a screening tool for sepsis that would be used on every single patient as they were triaged through the ED. And this is a screenshot of what our ED triage severity of illness screening looks like. And the nurses were trained, and whenever they identified two of the SIRS criteria through this screening, they immediately notified the doctor. This is what we have in the triage area. And I think that having that continuous nagging of the physicians whenever this was identified by the nurses actually helped drive getting that 3-hour bundle completed. So, like I said, this is kind of how it works. We started this in June of 2014. All patients are screened at triage. Do they have 2 or more criteria? No. Normal triage, you know, you may wait. Do you have 2? Yes. We get the doctor, we get him back, and we get him worked up sooner, and we start the 3-hour bundle. We did some physician education as well, and that helped, you know, them to understand why we needed to do the things we needed to do in a very timely manner. Okay. So you can see our progress throughout 2014. You can see the rapid compliance with that 3-hour bundle once we implemented that screening tool in the ED. And then our mortality, over the course of 2014, we really didn't see that dramatic of a decrease, like 11, what is that, 11 point, I'm having trouble seeing the numbers in the light, 11.7 to 11.4 possibly. But this year, we've continued to follow the sepsis 3-hour bundle this year. You know, we didn't know exactly when we were going to be required to start reporting the measures again, but we decided to keep up with it and abstract our charts and so forth. And I'm happy to say that in April of 2015, we did achieve 100% compliance on the 3-hour bundle, and our mortality rate over the course of the first 5 months of the year is at 9.6%. So, you know, we have seen some improvement there, so that's a really good thing to see. And I want to point out a success story that just happened last week with us too, that probably 2 years ago would not have happened. We had what I consider a younger man, 56, come into our ED on a Sunday. And he had had a prostate biopsy on Friday. And throughout the night on Saturday night, he complained of having some rigors, some chills. He had a low-grade temp, and he was tachycardic. And because of the awareness, our screening tool, because of the awareness of the staff, we got him in, we fluid bolused him, worked him up, got his antibiotics. He was in he recovered very rapidly, never became hypotensive. He was in the hospital only 3 days and was discharged after his antibiotic therapy. And when you think about how that could have gone the other way, if a patient comes to the ED, low-grade temp, tachycardic, a couple of years ago we might have made them wait, just thinking, settle down, it's anxiety or something like that. But I think that we really did save his life and save him some significant some debilitation after his hospitalization. Now the next steps are a little more challenging. We do need to sustain our gains that we've made with our early implementation of the bundle in the ED. And what we're looking at is, sepsis most of the time does come through our ED doors, but we recognize that sometimes it happens after the patients are in the hospital too. So we're looking at further screening more frequently for the SIRS criteria on all of our patients, and then using our rapid response team to respond whenever that occurs and get that intervention done earlier. We want to look at the 6-hour bundle, the new CMS 6-hour bundle, and see how we can work on that, because it is challenging for a hospital our size. How many of you have looked at the specs for that 6-hour bundle that we're going to start reporting in October? You can see that if the patient doesn't initially respond to the fluid boluses and the antibiotics in ED, then you're looking at some physician assessments that need to be done and documented within 6 hours, or some interventions like a central line that needs to be put in by the physician. And whenever you don't have physicians in the house 24 hours a day, that can be challenging, and I know that's a hurdle we're going to have to overcome with our physicians to convince them that this is something that we need to do. I do want to say, too, that one of the things that really, on a side note, no offense to any physicians in the room, but what we did to try to help drive improvement in the sepsis bundle in 2015 was with our ED physicians, senior management, knowing the importance of this initiative, the importance of performance, was willing to put a portion of their contract at risk. So therefore they docked them a percentage of their usual money they would get, and they're making them earn it back through quality measures, and they did make the sepsis 3-hour bundle one of the measures that they have to achieve to get their bonusing for that. So that was very effective. So I'll be happy to entertain any questions when all of us are through, and I'll go ahead and hand the remote back to Dr. O'Brien. Thank you.
Thanks, and please think about your questions. I think we were talking about earlier, the small hospitals, in my experience, have actually been some of the leaders around this because of the relationships, the tighter relationships, and being able to move things forward and some of that foundation of trust. Jim, I'm not sure who's talking next. All right, next is Carol.
Well, good morning. It's nice to be with you. I am here to talk about a different twist on what we've done, and that's really talking about, I've got some data to show you with regard to our LEAPT project, but I wanted to bring some emphasis to some of the work that we put into early identification and earlier rescue of patients, if you will. So we have a Code Blue emergency response team, and we've been working with them. Those are our partners from the James across the health system, in University Hospital and some of our others. And what we've done is we did a couple of pilots, or we did one pilot in each segment, and then we've spent some time kind of thinking through what our pilot results showed us, and then we're gearing up to do another pilot coming this summer, first quarter of our fiscal year. So we have had in place for a while, we implemented in the EPIC model the MUSE scoring capability, a modified early warning system, so our score, and that's been in place for a while. So that was not something new we introduced as this project. What we did introduce as this project is let's see if we can make a difference by identifying patients who have a score that's 4 or greater. And I'll tell you that the scores can be, you know, as high as 8 maybe, but those are very ill patients. So 4 is sort of a mid-ground for us in terms of identifying a patient that's had some changes. So we did a 2-week pilot. We got some of our units. We had 2 med-surg areas, 2 of our PCU areas. We trained the nursing staff. We talked with the physician colleagues that work in those areas. And then what we did is we got our stat nurse team, the ones that respond when we call an ERT, early response team, or when we call a code blue. So we got those teams together and said, well, let's try this for a couple of weeks. Let's have an automatic call out of any patient that has a MUSE score of greater than 4. And we trained the stat nurses to be able to, in this very short window of time, to really have autonomy in terms of reviewing the patient's condition, talking with the team, and then when necessary to go ahead and call it a sepsis code and invoke then the bundle compliance. So 3 hours, really paying attention to that. Now, in the James, remember we have a very unique population in that all of our patients are in hospital for some treatment of cancer. So they've either been treated or being treated or have been treated and are returning patients to us with the problem of cancer. So we scripted the stat team to be very specific about their concerns. This is a new onset of an infection. This is, you know, some change in the patient's status over the last few hours. What we really focused on, though, was early identification of sepsis. And what could we do? How could we make a change with that? Now, you know, part of the problem is in the cancer world, many of our docs probably see our patients that are septic, but we script it out as febrile neutropenia. So we aren't really using the word. So we really focused a lot on, let's just say it, if it looks like, smells like, could possibly be like sepsis, let's just draw out that word. So I appreciate what you said earlier about that. So we did try to emphasize we want that bundle implemented. And funny thing with us, when we looked at our LEAPT data, we realized a lot of cancer patients in the hospital are on antibiotics. So this wasn't as much about initiating a antibiotic. It was talking about, do we have the right antibiotic on board? And if not, change those orders and get something new going that would be appropriate for this. So, sorry, am I pushing the wrong button probably? So we did, this is some outcomes from that. We did see an increase in number of calls made, which caused everybody to kind of get a gulp in their throat, because it's a pretty big change for how you're staffing your team to be able to respond. And now remember, they're also responding to true code blues, true emergency responses that maybe have nothing to do with, so this was a pretty big volume increase for our stat nurses. We also, really looked at, how did we do about suspicion of sepsis? And you see up here, we had done a look at what we thought was the right number before the pilot, that about 35% of the time we were suspecting a patient was now septic. But after the pilot, we yanked that up to about 78%, a little over 78%. So I felt pretty good about that, because I felt like we did increase awareness, again, in a very short window of time. What really happened, though, was there was a huge dramatic shift in the dialogue that was taking place between our stat teams, the primary team and the primary nurses, and then our physician teams. And I think that really says a lot. In the cancer world, I talked with you about this once before, there's been this sort of debate, the lactate, maybe that's really not that important, it's not a good indicator for the cancer patient. But we said, oh, what the heck, let's try it anyway. So we did see a huge increase. I don't have the number on that up here, but we did have a huge increase then because of this momentum that we were putting around this to increase the number of lactate levels that are drawn. And what do you know? Some of those were elevated. So it did sort of prove to us that it's maybe a value worth looking at. We know that we had an increase at the bedside. Our clinical professional nurses really had a huge wave of knowledge come to them about sepsis in awareness of the Muse scores and how those could be tied together. We believe that the Muse score did help us catch some sepsis, and it was not just false alarms. And then, really that importance of giving the right intervention, early intervention to our patients on early identification. So what we learned, I think, was we want to be sensitive to alarm fatigue. So I think, we've been talking a lot about that since, 2014, and we want to think about that. Do we want to be constantly hitting the audible, if you will, it goes to their pagers. Do we want to be doing that? We've talked about doing a silent call so that we get the ERT nurses there, the stat nurses to the bedside to really look at those cases first. And then if we need to, call the teams down and have, sort of a bedside huddle of, this looks like sepsis, we want to do this, this, and this. We know that we don't have a good defined process that's written out in our medical records. So we are currently working on that, developing an order set that would help us really drive early intervention for those patients that we need the right orders in place. And then really looking at, what's our exclusion criteria going to look like. We know we had improved education, again, about the lactate. And this was another funny one. We found that we often think we're doing fluid resuscitation, but we really found, unless the patient says by signs and symptoms they're hypotensive, we really were just given a little bit of fluids, maybe a 500 cc bolus. So we really did learn that we've got to do a lot more about, capturing the attention towards fluid resuscitation earlier. Next steps for us, we have a new PI project underway, if you will, and again, this is not just only the James, but it's really with us linking arms with our sister hospitals and really focusing on this across the bridge. We really are thinking about how we could do this differently instead of only having the stat team be the one to sort of ring out to the others, the code sepsis. Is there a way we can create this with the bedside nurses to be able to evaluate the patient, consider or be suspicious that this is a septic patient, and be able to invoke the code sepsis for us. We've talked about, do we want to stick with the Muse of 4 or greater, or do we want to have a change in our thought about if there is a definitive 50% increase in the patient's, or a change, I shouldn't say increase, in the patient's reported vital signs and condition, should we then also use our modified or our response team? So we're going to have a second pilot of this sometime in the first quarter for our fiscal year, which starts July 1. And we know while the James is not caught in this automatic reporting cycle because of our PPS exempt status, it's important to us to be working side by side with the other hospitals in our system that do have this coming up in October. So we're focused on that. So here's a slide I have for you to look at that's really some of our LEAPT data, and what is I think, it's a lot. I kind of hate this slide, but then I also fall in love with it every time I look at it. So the blue bars represent our sepsis mortality ratio. So that observed over expected, observed coming to us from our own data, and then the expected being data that we get from UHC. And really, so that's the blue bar, and you can see over the course of time, and really we've been focused on this since about late in 2012, early 2013. So you can see that we have seen, I think, a fairly dramatic, although I don't have the statistics up here to show you that, a fairly dramatic decrease in our mortality, and I'd like to think that's because of all the talk and focus and, just saying the word sepsis more to everyone. The top line represents our case mix index, so you can see it's gone up a little bit. And then the green line is really, I'm sorry, I got that wrong. I think the green, it's hard to see up here, isn't it? Like, what does that say? And I looked at these just sitting over here before I got up here. I think the green line, what does that say? Cases. All right, so that's showing you that we've had an increase, a very dramatic increase in the cases of defined sepsis using the codes that we used with the LEAPT project. So I think you can see then the mortality rate has not gone down as much as I would like it to. I think very often a patient to the James presents into the ED setting fairly well recognized already in septic shock. Even some of our patients that are in-house are, sepsis is one of the diagnoses, unfortunately, that a lot of patients in the James do experience and die from. So it's still on our scope of things we need to do better. This is just another look at this, sort of to let you see that line of our LEAPT patients, looking at that particular population and how we did see a decrease in that mortality index. This is the funniest looking little slide, is it not? This is a funnel plot. And what I really wanted to show you here is, one of the things that we tried to look at with LEAPT was not only your mortality and what change could you make in that over the course of time, but we were all tasked with looking at our length of stay. And what this really shows you, because of the clustering around that median line, the red line in the middle of those two funnel lines there that are just representing the control limits, 2 standard deviations above and below, that we really are fairly well in control of our length of stay. So what I'm thinking this is teaching us is that we really don't have, for as many cases of sepsis that we see, it's not really bumping up our length of stay that much. I do think because we're very focused on it and treating it and trying to say sepsis and not febrile neutropenia as much. So I think that would be all for me. Yep. Thank you.
So I actually was at OSU prior to coming over to OhioHealth and left just about the time that things got better with sepsis. So I just want to make sure I make that disclosure. One thing about the NQF, the CMS measure, NQF 0500. So I think this is an example of if we're not stepping in and coming up with the solution, someone else is going to tell us what the solution is, and they rarely actually understand the problems we have in our individual hospitals. I'll disclose I was part of several rounds of appeals on that measure, and we managed to get some of it changed, but in all honesty, the people who sit and talk about that measure are largely insulated from the work that has to be done. And so while I absolutely agree with our need to measure, report, and drive for improved performance, none of them are working in hospitals where they would even imagine the notion that there's not a doctor there 24/7. It's not them, it's usually a resident or a fellow or someone like that, but it doesn't even occur to them as you talk to them on the phone that the majority of care that these patients are going to receive is in facilities that are not huge academic medical centers where doctors are tripping over each other. They need to understand the burden of data collection relative to then, do we really want people instead to be focusing on performance improvement? And I think that's something that National Quality Forum is still struggling with, quite honestly. And they've improved over the years, and I sympathize some with their challenge because they were charged with putting together a whole bunch of measures in a very short time window. So it's kind of like trying to change the oil in your car as it's driving down the highway. They're going to make mistakes, and they're trying to clean some of that up now. Our last speaker, coming from Akron, Christina.
Good morning. Thank you, Dr. O'Brien. It's such a privilege to be here, and I do thank OHA for this opportunity. And I also want to thank Dr. O'Brien for appealing some of those measures. My physicians would love to shake your hand.
I will accept checks.
I will let them know, so let us know the address and we'll send the money your way. With Dr. O'Brien being on that panel and appealing some of the measures with the 6-hour bundle has then increased a lot of our physician engagement, then being more dedicated to the 3-hour bundle. So again, thank you for that. So I want to share with you our sepsis journey that we had the privilege of working with OHA in 2014. We did utilize a lot of the Surviving Sepsis campaign elements as well in educating our staff. So we are very transparent at Akron General, so I'm going to show you some data as well with that, and that's the data that we provided OHA through that program, as well as our continuous data collection that we're doing in 2015. So really 2014 in summary and what we've done with OHA and our involvement in LEAPT, as well as our involvement in communication with other organizations throughout Ohio that were involved. We improved our ED course of care. We improved their knowledge of sepsis. It started with our residents, started with our attending physicians and nursing staff. So we really tried to expand the education to go across all multidisciplines that are within the ED caring for our patients that are hitting our doors. We also implemented Team Sepsis protocol for our CAT team, and that's Critical Access Team or Rapid Response Team. So we have employed our rapid response folks who are nurses in the ICU, going out to our medical surgical units who we are anticipating may be septic. So we did implement that. We are in the final stages of our electronic I-form for severe sepsis. However, we're going to expand that to not only include the ICU admission, but also the med-surg admission. As you know, unfortunately, some of our patients do hit our med-surg units, ideally not the best place, and we'll look at some of our data with that as well. Physician documentation has improved. As a QI coordinator doing all of our abstractions, it is fun to look at how our physicians and nursing staff are developing in their knowledge of sepsis and their knowledge of dictating, this is how the patient presents, and they're changing their verbiage. So it's very exciting to see that as we move forward. And down to the bottom line, we're increasing awareness. Increasing awareness with our medical staff, our nursing staff. We do have a long ways to go with community, and that is one of our visions as we move forward. All right, so here's some data on our length of stay. We have separated it out from simple sepsis to severe sepsis. You can see a very large spike there in February. We did have a lot of volume within February, as well as a lot of ICU admissions, and unfortunately we did have some of our patients housed in the ED for a period of time, which I'm sure accentuated some of our length of stay data here. So we're pretty much along the lines with our simple sepsis. I mean, we're staying pretty kosher there. We are doing much better in our severe sepsis, and I attribute that to knowledge with our ED and ICU staff. Our 3-hour bundle, again, we're very transparent. So here is our 2014 data for your review, as well as we're moving forward in 2015. So we have not stopped abstracting the data. There's so much more performance improvement that we can do for our patients in our community. So you can see how we've done on our lactic acid from beginning to our latest data of April. So we had a 50% jump in obtaining that lactic acid. And what we really honed with the lactic acid in doing our education is, when you think of MI, what's the first lab that you draw? troponins. So does sepsis have a troponin? Essentially not yet, but we're looking at the troponin for sepsis to be the lactic acid. So that is really our key indicator. Where is this patient at? Are they in any type of organ dysfunction? Let's look at the lactic acid result. Blood cultures, we have an opportunity there. We did have a lot of discussion about the value of doing 2 blood cultures in our ED, and that was the final decision with that. So we do have some movement to go with that. Broad spectrum antibiotics. We identified that we have satellite EDs, and those antibiotics are stored there. And we identified they have better outcomes. Our patients have better outcomes as they're transferred to the main campus from our satellite EDs versus our main campus ED. But however, we do have a pharmacist there, almost 24 hours a day. I want to say they start at 7 and they conclude at 11 p.m., which has helped a lot of our broad spectrum antibiotic timing. So they're not stored in our main ED, but however, we do have a pharmacist on feet that can help us get that to the bedside quicker. All right, antibiotic timing. As Dr. O'Brien pointed out that for every hour of antibiotic timing beyond the 3-hour mark, you're looking at an increase of mortality. It's unfortunate. 7.6% is pretty high. So you can see how we have done with our antibiotic timing, but it's unfortunate. Also, some of our patients, we didn't have an antibiotic administered at all. So we do have a lot of opportunity regarding identifying, is that patient septic? And if they are, they severely septic. So we do have a lot of improvement to do there too. Admission dispo. This was another piece that we wanted to look at because as you can see how severely septic a patient can be, that increases their acuity, it increases their need of more bedside medical care. It's unfortunate some of our patients saw the med-surg unit first. So we looked at those, we drilled down to each of those, and I apologize, there's a lot of data here, but I wanted to exemplify to you the importance on getting them to the right place the first time. This is a core measure for our ED care, but however, the ICU has to help us continue that care at that appropriate acuity level for that patient. So when you send a patient to a med-surg unit and they're severely septic, we're looking to see if they require a transfer into ICU within the first 24 hours. It's pretty scary. Imagine yourself as a bedside nurse on a medical surgical unit, 6 patients, 7, maybe 8 on a bad day or a night, and you're receiving your ED admission who's severely septic. Blood pressure starts to drop. You have antibiotics hanging. Then you have to do more fluids, calling the physician, perhaps your rapid response team if you're identifying their septic. So there's a lot of things that we need to do for that patient to better their outcome and hopefully avoid mortality. So I wanted to share with you a case in review. This is a 42-year-old male. He has no medical history. He has no medications on his MRF. He presented to our outlying ED at 1:49 in the morning. Blood pressure is elevated for him. Pulse is elevated. Respiratory rate is also elevated, but his temp is normal. So if you look at him initially, he meets SIRS criteria, taking a look at his temp and his respiratory rate. WBCs, they're good. Platelets, okay. Sodium, potassium, creatinine. Again, this is a normal 42-year-old male, no medical history. So if you look at this, he meets SIRS, and he meets organ dysfunction if you look at his creatinine, because that creatinine is elevated. We identified that he ended up having cellulitis upon transfer to our main ED at 3:08 in the morning. So he's remained stable through that ambulance ride. Hitting our main ED shortly after, we now have a blood pressure of 83/55. He now went into shock. How quickly did he go into shock? Pulse remains elevated, respiratory rate 20, temp remains normal. So now we have infection, we have SIRS, so we're meeting sepsis criteria. We're meeting severe sepsis criteria with his creatinine of 2.15. Now we're meeting hemodynamic instability as shock. Unfortunately, this young man was admitted to a medical surgical unit with a diagnosis of cellulitis. So at 1:30 that afternoon, We then drew a lactic acid. Again, lactic acid for our organization is the troponin of sepsis. We did not identify him as being septic. So lactic acid is 7.5. Within this time frame, we drew with some additional labs, 7:30 in the evening. WBCs are now elevated. If you remember, WBCs were 8.3. We've doubled. Platelets, sodium, potassium, and here's our creatinine, 2.58. So his organ dysfunction is increasing that much more underneath us, underneath our eyes. So he's decompensating minute by minute. Transferred him to a higher level of care. He ended up going to OR, emergent OR. Unfortunately, throughout this very small span of time, which you can, if you remember right, we're looking at 12 hours. Add another few more hours, so now we're looking at 18 hours. He is now intubated. He's now on pressures. He's now getting every blood product you can imagine. IV fluids. Unfortunately, this young man lost his life. Length of stay, 4 days. We did not identify it. It's a sad case, and I'm sorry, there are sad cases with sepsis, as Dr. O'Brien shared with you the picture that's on his wall. What could we have done differently to identify this young man to save his life? We're still questioning ourselves. Was it fluids? And I think I failed to share with you how much fluids we gave him, and when he initially presented, we gave him less than a liter when he came to us at 3:08. Now, based on fluid resuscitation, it's based on your weight. So based on his weight, he should have received 2,100 cc's fluid bolus to get his blood pressure back up. He received less than a liter. We did not continue those liters when he went to the med-surg unit. So for this, it is a case that we are learning from. I wanted to present this to you to also learn from. When we spoke about this very openly in our monthly meeting, where did we miss the ball? And unfortunately, our ED nursing staff said, well, you didn't have a temperature. So take this message home that you don't always have to have a temperature to be in severe sepsis, to be in sepsis. So take a look at everything your patient is presenting you with. And as Carol said, why not sepsis? Always question why not. So moving forward, these are our goals for 2015. Education. We've done a lot of education with our ED staff, our ICU staff, our rapid response team, but we do need to expand it to our med-surg units, as you can tell in the case that we had reviewed and discussed. Family engagement. It's always good to engage your family, to have that difficult conversation. So we will start the materials in which we will present to them the conversations, and then also engaging and employing our medical staff to have that conversation, how difficult it may be. Completion of order sets. Hopefully those will roll out here in the next month or so. We're continuing our physician and nursing case reviews. We learn from our cases, good, bad, and ugly, and you have to take each and every one of those. You have to congratulate your staff for the kudos, but then you also have to take a look at cases to see where you can improve on performance improvement. Data collection, we're going to continue with that as well. And I really do have to, our organization is so well engaged in leadership that they have added sepsis to our strategic plan. So this data is being reviewed by board members, by our higher leadership, our middle leadership, but we do need some additional engagement from our physicians. Again, moving forward, we're going to continue our efforts in evidence-based practices. So as we move forward with OHA, as we move forward in seeing how CMS will develop this as a core measure, new initiatives in sepsis care. So taking a look at what does research say? How can we incorporate that into what we do every day? And the baseline awareness and recognition. I think we've done a really nice job in our organization increasing the awareness. How many of you have a magnet on your refrigerator at home that talks to you about stroke or a heart attack? My goal is to get a magnet also on your refrigerator that talks about sepsis. All right. That's it. Thank you.
So I want to thank all of our panelists for having the courage to go first and to share the challenges that we've had. Just so you know, Christina, so If you go to the Sepsis Alliance website, you can actually get a car magnet or a refrigerator magnet today that says no sepsis, K-N-O-W, with the no in a different color. So mine actually faded in the sun. Anyone who has a question card, please raise it so we can pick that up. I'm going to prioritize the questions that were submitted for the panelists so we can call on the collective wisdom. But please, if you have a question that we don't get to, because you guys did a great job submitting them, then please come up afterwards and communicate with us. So the first one I want to open up to the panelists. What would you guys say was your number one barrier? And feel free to select either a barrier you overcame or one you're still struggling with. Christina, you want to start?
Is this working? Is there a button here?
I don't know. How do we turn these on?
Can everyone hear me? Usually I have a loud voice. So I feel that our biggest barrier is physician engagement, because when we started the severe sepsis campaign with OHA utilizing the LEAPT program, we were collecting data for both the 3 and the 6 hour bundle. And our physicians were very resistant on the 6 hour bundle. They would collectively bring numerous piles of evidence and research based articles to our monthly meetings to say, you know, pressors might not be the best way. Central line insertion, at the door is probably not the best way. So we did have a lot of resistance with that. But as Dr. O'Brien and his team worked on appealing some of those things, we're now gaining some of their engagement to say, okay, the 3 hour bundle, each one of those elements is impactful. It does not increase patient harm, so let's go ahead and move forward with that. So still a very small struggle, but certainly not as big as it was when we began last year.
I would say simply the awareness of physicians and nurses that sepsis is indeed a preventable cause of mortality and morbidity. I think it's still regarded, it's become a little better, but I think it's still regarded as something that happens. Oh, well, it's a complication of another disease. It just happens.
Yeah, I think there is more than one barrier, and I work with great colleagues across the health system at Ohio State, but it's probably addressing culture, the culture of, and being sensitive to creating a change in the momentum that needs to go around this. And I would also say medical record changes. That's hard in an electronic medical record world, as big as we are, to create a change and be nimble with those changes as we go along. So,
one of the questions that we have is related to engaging frontline staff, and particularly around pushback or questions about the validity of some of the sepsis bundle, for example, some of the stuff that either Surviving Sepsis Campaign or CMS National Quality Forum wind up putting forward. How do you guys deal with that sort of resistance?
Yeah, I'll start with that. I think one of the things that we did was really early on try to have representation on our committee, mostly from clinicians at the bedside, both physicians, residents, nurses, the whole team really was represented. And then they really became our ambassadors for change. So really using them, to be proactive in the voice of raising awareness about sepsis and engaging the teams. And, I think that was one of the ways that we were successful with this.
I would echo what Carol said about it, using the frontline staff on your committees. We did do that with our nursing staff, and of course we had some physicians involved as well. But ever since 2006, whenever we started reporting core measures, we're fortunate the hospital did put a high degree of emphasis on performance in those core measures. So it was kind of like, this is just a new one that's coming along. So people tended to look at the evidence with the specifications and so forth, and they didn't really push back the evidence. They pushed back at having to make a change in their behavior somewhat. But engaging that frontline staff on your committee was helpful.
Thanks, Christina.
Our frontline staff, I believe, were screaming for this. The ED nursing staff was so excited that we were finally focusing a lot of our efforts on sepsis and that patient that presents in that fashion. So I would think with the barriers, it's the physicians and engaging them, getting them to come to our meetings, talk about sepsis, being involved in educating not only your peer attendings, but also your resident staff. So just really kind of making sure your elbow is in every element, every educative opportunity for the medical staff is something that is improved and decreasing barriers.
So a couple things I'll offer in some of the work that I've done too. There's a equation out there for overcoming resistance that came forward in the business literature in the 1980s. And it was, to overcome resistance, you need to have the product of the dissatisfaction with the current state, the vision of ultimately what's possible, and the initial first steps that can be taken. The product, meaning you multiply those factors together, has to be bigger than the resistance. What that means, if any of those components is a zero and there's any resistance, it's not going to work. I think that for me, one of the things, and my team gets really sick of me saying this, it's important for us to be really clear about the problem we're trying to solve. Because if the problem we're trying to solve is adhering to a core measure, as a former clinician, that doesn't resonate with me. And particularly when, I will be quite frank, some of the data and some of the evidence supporting both the bundle but also the Surviving Sepsis campaign is low-level data. The 20 to 30 mLs per kilogram isn't based on anything. It is made up. The reassessment by physicians in patients who have refractory shock, made up. So for us to go to our clinicians and say you have to do this because it's made up, I think we have some opportunities actually here for being transparent and for acknowledging that and instead asking them, okay, what do you think we should do? And put the measure aside. Because what that's going to get you is it's going to get them engaged around it of what they see as the opportunities. You know, it's really hard for me to order antibiotics. Let's work on that. Some of the traction we've had before was focusing, instead of time of presentation to antibiotics, time to when they were ordered to when they were administered. Because from a physician standpoint, I have in my head this belief that there is a Zosyn fairy. I feel like someone should get Zosyn, and it just happens. One of the things we found at Ohio State is, depending on the way I ordered it, may result in a delay on average of 2.5 hours to administration. And it was because of the backside workings in the pharmacy that the frontline clinicians didn't know about, didn't care about. And so when we started focusing on that piece of, you know, it can be really hard to pick these patients out. But once you want to give antibiotics, is there ever a time that you want to wait 4 hours? And universally, the answer was no. Ron Daniels, who is working on this, the National Health System in the UK has identified sepsis as something they're going to work on. They lose about 32,000 residents a year, so about 8% of what we wind up losing in this country, but they've said enough, we're spending too much money, and Ron's their point person for basically the equivalent of the Sepsis Alliance over there. Ron's promoting something they're calling Sepsis 6. What he finds is that the complexity of these bundles are such that it makes it really hard for frontline clinicians to understand it. And so what he talks about is 3 treatments and 3 diagnostic procedures. The 3 treatments are oxygen, fluids, and antibiotics, and the 3 diagnostic procedures are lactate blood cultures and urine measurement. That's it. And let's start there. So I think this provides us an opportunity to have a framework of engaging our frontline staff about what do they think we should be doing? How should we start? Because if they are getting engaged in it, now they also own the success of it. They have what's called an endowment bias. An endowment bias is why we think our kids are the greatest kids ever. They're the first kid that ever went to the bathroom on a potty, right? It's because we've invested in them. And so as a result, it has value for us. We need to get them with an endowment bias about that. And it's rare that winding up doing that, in my experience, does it. What will happen is they'll manage the metric. And so you'll get a lot of box checking, but not the thoughtful approach to let's make sure that we're providing the best care. All right, some focus questions. So Carol Colussi, it seems like foot soldiers are the nursing staff. How do you educate the competency and screening process house-wide?
Say that again.
How do you educate and teach the competency for the screening process house-wide?
Well, that's part of this pilot that we're going to initiate in July and really try to look at At our University Hospital East, we're going to do house-wide sepsis screening. So we're in the process of, developing that competency for those nurses, and really how are we going to ensure that, the identification is accurate and appropriate. Using the Muse score is one of those things that we've been doing for a while, so that's a competency that's already embedded. But we certainly will have, our educator groups really working with the frontline clinicians. So more to come on that by next year, because this is an early endeavor for us yet.
And then both for Carol Murphy and Christina, some questions about how you guys do your case reviews. So do you have a standard form that you use? Do you include cases where it was missed, or only ones that we started some therapy? How do you guys go about doing that?
We developed we actually, LEAPT gave you a specifications manual, essentially, who you look at. So first of all, by coding, you identify the patients by coding, and then we developed reporting of our measures according to that. Did they get the lactate? Did they get, the blood culture before the antibiotic, and so forth? And we use MIDAS for our measure abstraction currently, and we were able to build a custom focused study within MIDAS to use for sepsis. So that was really nice, because then we could just do that report whenever we would report an aggregate for the LEAPT project. And I hope that answers the question that was being asked. But basically, we received the specifications on how to abstract those measures, and we do have our sepsis coordinator did that abstraction.
We mirror. So we also utilized MIDAS, and we also created a focus study, which was nice because at this point we can tailor it to what we want to collect. So we're not just collecting the 3-hour bundle elements, but we added a lot of other things that we wanted to look at. How is the ED verbiage and dictation? Did they identify that this patient is septic, yes or no? We're also looking at, and this is really only the tip of the iceberg, how that patient's presenting on January 1st. Did we have an admission in December? Did we miss something in December? So we're looking at the previous 30 days, and we're also looking at 30 days after discharge. So we're looking at really a span of 60 plus days of patient care if there's any additional admissions within that window. Where did we go wrong? Did we miss something? Was this patient a UTI in December and now it's a recurrent on January 1st? What can we do to improve? And with our case reviews, we do it in a couple different fashions. We are now including a case or two in our monthly meetings for open discussion. And that's how we identified that our nursing staff was focused on temperature. We don't have an elevated temperature, so we're not septic, we're not, infected, whereas there are several other elements that you can identify and look to see how your patient is presenting to you. But then we're also looking at case reviews for our physicians. So we are providing physicians feedback. You're doing well here. I see there's excellent ED verbiage dictation from physician nursing. So they're not only hearing the bad stuff, because you should be 5-1, which is difficult right now in the sepsis realm because we're focusing on how can we improve, but yet we are doing good things too. So giving them kudos on measures that we're meeting, but then also identifying and reviewing cases such as the one that I shared with you earlier for physician and nursing peer review. What could we have done differently? We need to learn from this. So several different realms for our case review and use of MIDAS as well.
And then as you three are doing these case reviews, are you finding commonalities as far as patient characteristics, whether it's comorbidities, age, anything else, or are you not seeing any clear patterns? Christine, you want to start?
Mm-hmm. When we first started doing a lot of our sepsis data collection, we looked at comorbidities, and it was almost hand in hand. A CHF patient or COPD was our highest associated comorbidities with that patient who presented severely septic. So we are seeing association. There's not an association for age. They're coming as young as 17 to as old as 101. So it really doesn't, we haven't found that to be an association, or where they're coming from, whether it's from ECF or home. It's pretty down straight down the middle for that. However, we are seeing more home readmissions, which we were very surprised, versus ECF. We assumed that many of our readmissions would come from ECFs, whereas it is just vice versa. So really it's just the comorbidity piece that we found to be associated.
This is where I really wish I had Bonnie here, because she would intimately know all of this and be able to report like Christine did. I do know that pneumonia is highly associated with sepsis in our organization, but I'm sorry I can't give any further detail and breakdown.
I don't think we found any specific trends. A lot of our patients are so in a state of debilitation that when they present, they've got lots of comorbidity. So I can't tell you that we looked at it, but there really has not been any one thing that stood out to us. A fair number of our patients do start from our ED admission, but our ED colleagues are so right on this. I mean, we are delivering antibiotics in less than 2 hours now. So we're pushing them to get to the 1 hour mark, but yeah.
I think this is one of the struggles we have, is that it can be very difficult to identify these patients. And again, I think that we have the opportunity to be very transparent as we're working with our clinicians. And is there a group that is more obvious? So the septic shock patients, if we don't have a good reason for them to have low blood pressure, we probably need to rule out sepsis the same way we rule out myocardial infarction with patients with chest pain. We need to start thinking about that vernacular for our sickest patients. But I think starting with the patients who are the grayest is going to be a real challenge. So how do you start getting them engaged around that? So we're at the 10 o'clock time. Please join me in thanking our panelists for their contributions. So just in closing, I want to thank all of you who have signed on to the OHA project. Know that whether you're part of that project or not, please feel free to consider me a resource. You can reach out to me via email. My email address is knowsepsis@gmail.com. And feel free to take advantage of any of the resources, for example, that we have on Sepsis Alliance's website. Our mission is to try and provide resources for better communication, better awareness, that interface between healthcare and the public. We feel like that is an essential piece of the formula for defeating sepsis. So we want to make sure that those are available to you. Let us know if there's more content that you need. Thank you very much for your attention and for your commitment today. And we're going to go ahead and have a break. Thank you.